Hello, everyone. Thank you so much for tuning in today. My name is Abigail, and I am the health educator for the Pink Ribbon Place. This presentation is about childhood leukemia and lymphoma, and I'd like to give a huge thank you to the Leukemia and Lymphoma Society for this collaboration on this presentation. This presentation has been pre-recorded, but if you have any questions, please put it down in the comment section down below. Thank you so much.
All right, good afternoon, everyone, and thank you for joining us for our program today. In honor of Blood Cancer Awareness Month and Childhood Cancer Awareness Month, the Pink Ribbon Place and the Leukemia and Lymphoma Society, or LLS for short, have collaborated to put together today's program on childhood leukemia and lymphoma. So my name is Lily Evangelista, and I am the Patient and Community Outreach Manager for the Greater Los Angeles region of LLS. Before we get started, I did want to talk about the resources available at LLS that are available for families who are impacted by blood cancer. So our mission is to find cures for blood cancer and to also ensure access to quality care for those who are experiencing blood cancer. So we do provide, while we do fund research, a lot of research, and do advocacy, and we also provide support for patients and family members. Right now, for example, in terms of research, we do have our children's initiative that we are spearheading, which is a collaborative groundbreaking program where we're really focusing on finding cures and better treatments for blood cancers that are affected by children. So that is something that you can support if you're interested in it. But for right now, I did want to talk about how we are here to help. We do have information specialists. These are master's level oncology social workers and nurses who are available to you and are able to connect you with all of the different resources that we have available at the Leukemia and Lymphoma Society. So this is a really great touch point. You would just have to call the 1-800 number that's on your screen right now, but you can also jump on lls.org and be able to connect to an information specialist through there. From there, you'll be able to get a lot of different support resources, including our Patty Robinson Kaufman First Connection program, which will allow you to connect patient to patient or parent to parent in this program. So getting that peer-to-peer support from somebody who's really been there. We do have online chats and support groups, as well as LLS community. All are happening online right now during this COVID time. We also have a lot of different financial support resources for individuals. This is including patient aid. We have an urgent aid program specifically for pediatric and young adults. Right now, we have a national travel assistance program available for those who are experiencing pediatric blood cancer. So you can look all of this up on lls.org, as well as a personalized nutrition consultation. In addition to that, we also have a lot of educational resources, including patient education programs like this one that are both online and when we're allowed to in person, a lot of free educational materials that we can have mailed to you directly, as well as other videos and podcasts, which is not on this slide, but that's also available. So that's all of the resources that we have available, and I hope that you're able to take advantage of it. So without further ado, I'd like to introduce our speaker for today. So she is the clinical assistant professor for David Geffen School of Medicine at UCLA and practices clinical pediatric hematology and oncology at Miller Children's and Women's Hospital Long Beach. So we're very appreciative to have Dr. Maritza Ruiz with us today.
Thank you for that introduction. I'm happy to be with you guys today to talk a little bit about blood cancers. So some of the topics we're going to cover today are what are blood cancers? What are the different types of blood cancers? What are some of the treatment options? clinical trials and survivorship, as well as some questions and answers. And this is specifically looking at the population of pediatrics, adolescents, and young adults. So before we talk a little bit about blood cancers, I want to make sure we talk about blood in general so that we can understand how these blood cancers develop and affect our bodies. So first, let's just review what is in our blood. So in our blood, we have different blood cells, and we also have plasma. So when we look at the blood cells in our blood, we have white blood cells, red blood cells, and platelets, and all of these cells have a different function. Our white blood cells are really important in fighting off infections or fighting off something that is foreign to our body and not supposed to be there. Our red blood cells are what carry oxygen to all of our tissues and organs, and our platelets play a very, very vital role in preventing our blood from bleeding. So they play an important role in blood clots. And our plasma is primarily composed of mainly water, but it has really important vitamins, minerals, proteins that also play an important role in helping our blood clot. So next slide, please. So the other important part of our body that we're going to learn about is the immune system, because this plays a very important role in the development of blood cancers. And these are different things involved with our immune system. We have our bone marrow, which is the spongy tissue that's located in the center of most of our bones. And this is actually where blood cancers arise from. And we also have lymphocytes, which are very specialized white blood cells that can develop in the bone marrow. They can also be produced in the spleen and are also located in our lymph nodes. Lymph nodes are the small glands that we have throughout our body, as you can see in this picture. It points to the different areas where we have a cluster of these lymph nodes or lymph glands. And they play a really important role in our immune system because they basically filter out our blood to make sure that we're cleaning out things that aren't supposed to be in our body. And so most of these little lymph nodes are clustered in our neck, are clustered under our armpits in the axilla. It goes throughout the middle of our chest in the mediastinum, down to the abdomen, and also in our groin area. And the spleen is an organ that it plays a very important role in our immune system, and it also filters out our blood to make sure that it gets out any abnormal red blood cells that aren't supposed to be there, and plays a very important role in our immune system as well. So what are blood cancers? Blood cancers that we're going to talk about today are primarily leukemia and lymphoma, and they can affect the bone marrow. That's usually where they arise from. And then they get pushed out into our peripheral blood and can also go to sites such as the lymph nodes and other parts of our lymphatic system, like our spleen that we just talked about. Blood cancers can affect people of all ages, including children and teenagers and young adults. They can affect people of all different races and ethnicities and genders. And blood cancers can either be very acute, meaning they happen all of a sudden and can be very severe, or they can also be chronic, where it happens over a long time and its symptoms can be a little bit more slow to develop. So the different types of childhood and adolescent and young adult cancers are leukemia, lymphoma, and other solid tumors. We're mainly going to focus on the leukemia and lymphoma. So there's different types of leukemia. The most common type that we see in children is acute lymphoblastic leukemia, and that can be further categorized into the different cell lineage that it's affecting. So the most common is B cell acute lymphoblastic leukemia, also known as B cell ALL. And there can also be a T cell ALL, or there can also be a combination of different lineages. The second most common is AML, that stands for acute myeloid leukemia, and it affects a different lineage of cells. It's the myeloid cells that it affects. And there's also chronic myeloid leukemia. This type of leukemia tends to be more common in adults, but we do see a percentage of children that also develop this as well. And in lymphoma, there's mainly two categories of lymphomas that we talk about. It can either be a Hodgkin lymphoma or a non-Hodgkin lymphoma. So let's talk about those types of cancers a little bit more in detail. So leukemia and lymphoma actually make up a pretty big percentage of cancer in children, adolescents, and young adults under the age of 20. The most common is leukemia, and as I mentioned, the most common of the leukemia is B-cell ALL. So leukemia makes up almost 25% of cancer in children, adolescents, and young adults. The second most common is brain tumors, which we're not really going to focus on today. And the third most common is lymphoma, either non-Hodgkin or Hodgkin lymphoma. As you can see here, the survival rates for children and adolescents with the different types of leukemia and lymphomas is actually quite high, with most of them being above 90%. So what causes blood cancers? I have to say this is probably the most common question that I get asked in every new patient that gets diagnosed with leukemia or lymphoma. Parents always want to know what caused this cancer, what did I do or didn't do to cause this? And I want to make sure that everybody knows that these blood cancers are not something that's caused by something that you did or you didn't do right. Most of the time, we actually don't know exactly why a child or adolescent develops a blood cancer. So the majority of the time, these cancers are not something that is genetic or inherited. There are a very small percentage of blood cancers that are inherited. And usually we can tell that by getting a very good and detailed family history. And we also do some tests if needed, if there's a very strong family history, to try to figure out if this is something that's inherited or genetic. But most of the time, there just happens to be some sort of damage or change to that specific child's DNA or genetics that causes this cell to become abnormal and start growing uncontrollably to cause the cancer. But the majority of the time, we're not going to know exactly why it happened in that specific child. But it's usually not due to something that was done wrong or anything like that. There are some possible risk factors that we do know about that can increase your risk for developing these genetic changes. So we do sometimes ask about, has there been a lot of exposure to radiation, like excessive doses of radiation? Have there been potentially some exposure to certain viruses that are known to kind of trigger the development of cancer? Also the exposure to specific chemicals that may trigger the development of cancer. There are some children or adolescents that may have another disease, such as an immune disorder. And when the immune system, when there's already a defect in the immune system, that can increase our risk for developing leukemias and lymphomas. And also, unfortunately, certain cancer therapies, such as chemotherapies, can also increase your risk for developing a different type of leukemia and lymphoma. So we'll ask about that history as well. Some of the signs and symptoms of blood cancers can be very nonspecific. So there's not really one specific symptom that I would say automatically means that you should be worked up for cancer. A lot of these signs and symptoms can be seen with even like the smallest little viral infection. So we really have to put the whole picture into play and look at how many symptoms is this child or adolescent actually having, and how severe are they. So things like fatigue, feeling tired, maybe sleeping more often, not having the energy to do the things that the child normally does, can be a symptom. Chronic infections, so getting sick frequently and having severe infections can be a sign. Sometimes these children can manifest with excessive bruises and something we call petechiae, which look like little red dots on the skin, almost like a rash. And any active toddler, any active kid can get a lot of bruises. So I don't want parents and family members to get nervous about like bruises on the shin, our legs, which is a very common area where toddlers and active kids can get bruises. But if they're getting bruises all over the body and maybe, rare areas like the stomach, the back, the chest, places where we don't usually bruise, like the face, those can be signs that warrant a further evaluation. Also fever. Fever is so common in children. We catch colds all the time. We catch viruses and infections all the times. So fever doesn't necessarily mean that your child has cancer, but if your child is having high fevers with no specific cause, meaning they're having fever, but they don't have a cough, they don't have a runny nose, they don't have other symptoms of being sick, or they have very high fevers that are just not going away. It's been over 7 days and they still have a fever that's not getting better. Again, that may warrant a further investigation. Unintentional weight loss or unexplained loss of appetite associated with this weight loss means that we should further look into why this is happening. Sometimes headaches, persistent headaches that are new, that are severe, should be looked into. Pale skin can be a sign of anemia. Pain, sometimes pain is a manifestation of a blood cancer. It can be pain usually in the arms or the legs, not wanting to walk and play the way they used to. Sometimes there's pain in the stomach because our organs can actually become swollen, like our liver and our spleen. So our spleen is located up on the left upper quadrant of the stomach. There could be pain there. Any generic symptom like even, new nausea, new vomiting, chest pain, any new bumps under the skin. These bumps can either be an actual mass, like an actual tumor, or swollen lymph nodes, like I mentioned before, in our neck, in our under our armpits, in our axilla, in our groin area. Sometimes swollen gums can also manifest as leukemia. Prolonged bleeding that you may notice after just a minor cut where you usually wouldn't bleed like that. You can also have bleeding of the gums more easily when you brush your teeth. Also just chest pain, shortness of breath, those can all be some symptoms that we see. So what is leukemia? Leukemia is a type of cancer that begins in the bone marrow. So this type of cancer manifests in the blood, and it's what some people call cancer of the blood or blood cancer. So what happens is that you have this abnormal cell that develops. This is your cancer cell, and we call it usually a leukemic blast. So this is the abnormal cancer cell that develops in the bone marrow. And because it starts to grow very rapidly, it tends to take over the bone marrow. So the bone marrow, which I like to call our factory, this is our factory that produces all of our blood cells, our red blood cells, our white blood cells, and our platelets. And when this leukemic cell starts to grow in our bone marrow, it basically takes over our bone marrow so that our bone marrow is no longer able to do the normal things that it should be doing. So it stops being able to produce these normal red blood cells, these normal white blood cells, and these normal platelets. So a lot of the times when leukemia develops, our other blood cells become very abnormal. Usually they can become low, but sometimes the white blood cells can also become very, very high. So when our red blood cells become low, this is called anemia. And some of the signs and symptoms of anemia are pale skin, feeling tired, feeling short of breath with any little activity, and headaches can sometimes develop too from being anemic. Now, just because you have anemia does not mean that you have leukemia. There's a lot of other more common things that can cause anemia. If you have low platelet counts, we call that something called thrombocytopenia, which is very difficult to say. But basically, that just means you have low platelets. And when you have low platelets, you may have a higher chance of developing easy bruising and easy bleeding. When you have low neutrophil counts, neutrophils are a type of white blood cell, then we say you have neutropenia. And when you're neutropenic, this can increase your risk for developing infections or having a hard time recovering from infections. So how does acute lymphoblastic leukemia develop? So as we mentioned before, there's this abnormal proliferation, this abnormal growth of these leukemic cells. And the majority of the time, we don't have a clear answer as to why this happened to the child, but something went wrong in the genetics of that specific cell, which made it start to grow uncontrollably. And when these leukemic cells take over the bone marrow, we stop producing our normal blood cells, which is why a lot of the times patients with leukemia present with anemia, feeling tired, feeling fatigued, easy bruising, easy bleeding, those kinds of symptoms. So who is affected? The peak age of children with leukemia occurs between the ages of 1 to 4. But it can really happen in any age group. So there's also older kids that are affected, teenagers and young adults can also be affected. So this peak kind of decreases the older the patient gets. And ALL is the most common cancer in children, adolescents, and young adults younger than 20 years of age. So how do we diagnose leukemia? So first, we end up getting a very, very good history on what are the symptoms of the child, what are the symptoms that made us draw these blood counts to see if they were abnormal. And once we have an abnormal complete blood count, that's going to be just from a simple blood draw. We can see that there's abnormal white blood cells, abnormal red blood cells, and abnormal platelets. And that's usually what makes us move on to do a special procedure to make the exact diagnosis of leukemia. And this procedure is called a bone marrow aspiration and biopsy. This procedure is usually done in the back of the pelvic bone, as you can see in this picture. We can actually have the child lie down flat or lie down on their side, and they are given medication to sedate them. So we do give medication so that they can go to sleep. They don't feel the pain involved in this procedure, and they won't remember what happened during this procedure. So they are asleep during this procedure. And we also give some local anesthesia to the skin where the needle gets inserted. So they also are numb in that area, so they don't feel any pain. And we're able to put a special bone marrow needle into that area, and we go into the bone marrow, as you can see into this picture here, and we're able to aspirate. We're actually able to draw blood from the marrow, and we're also able to get a tiny little biopsy of that marrow using this special needle. And those tests, that blood and that biopsy, are then ran for special tests. We look at the genetics of those leukemic cells, and we also do some molecular testing and flow cytometry to figure out exactly what type of leukemia the patient has. Usually at the same time that the patient is being sedated for the bone marrow aspiration and biopsy, sometimes at that same time, we will then do a lumbar puncture, or it might be a separate procedure. But a lumbar puncture is when we take a small spinal needle and we're able to actually insert it into the back, into the middle of the back. And this needle goes into the spinal canal where we're able to collect fluid. This fluid is called cerebrospinal fluid, and it's the fluid that surrounds our brain and our spinal cord. And we're able to collect that fluid and actually test it to see if there's any abnormal leukemic cells or lymphoma cells in there. And we're also able to give medication at the same time into that spinal canal to make sure that we are treating whatever cancer cells may be there and also preventing any cancer cells from getting to that area. So I talked a little bit about some of the chemotherapy that we can put into the spinal canal, and that is our central nervous system prophylaxis. So that's basically the treatment for any cancer cells that may be in that area and can also prevent any cancer cells from going to that area. But in order to treat the actual leukemia, we need to give a medication that's called chemotherapy. And there's a lot of different types of chemotherapy. And we usually use several different types of chemotherapy. Some are taken by mouth, some are actually given through an IV or a special catheter that we place, and some is given intrathecally into the spinal canal. And there's different phases of chemotherapy depending on the type of leukemia that you have. The first course of chemotherapy, the first phase of chemotherapy is known as induction. And the goal of induction is really to put the patient into remission, which means we're trying to get rid of all the leukemic cells that they have. There's other types of therapies. Pause. Do you guys hear do you guys hear? So some of our newer therapies are called immunotherapies. And we're now starting to incorporate immunotherapies into treatment for leukemia. And these immunotherapies are different from chemotherapy because they're actually targeted medications that attack just the cancer cells. And one of the immunotherapies that we have been using in chronic myeloid leukemia are called tyrosine kinase inhibitors. And because in chronic myeloid leukemia, there's a very specific mutation that occurs, and we're able to target that specific mutation. Stem cell transplants are also used in treatment of leukemia. It's usually not something that's used upfront in treatment, but in patients where the leukemia comes back or the leukemia is not responding well to standard chemotherapy, then we look at using stem cell transplant, also known as a bone marrow transplant, to cure the leukemia. Radiation can also be used in leukemia, especially if we have found leukemia that has entered the cerebral spinal fluid or the central nervous system. We do use radiation to also make sure that those leukemic cells don't come back to that area. Now we're going to talk about acute myeloid leukemia. So in acute myeloid leukemia, again, there's an abnormal proliferation of cells, and these cells are myeloblasts. So the myeloid cells are affected here. And again, this occurs in the bone marrow. So it's very similar to the other type of leukemia where you have these myeloblasts that have basically taken over and started to grow in the bone marrow. And it's preventing the bone marrow from producing the other normal blood cells that it normally makes. And in AML, acute myeloid leukemia, there are a lot of different subtypes. based on the genetics of that actual leukemic cell. So anybody can get AML. It can happen in infants and children, adolescents, and young adults. And the chance of getting AML it all actually has a bimodal peak. So it can occur in children and also older adults, especially after the age of 60. So it accounts for 20% of childhood leukemia cases. And AML also has a lot of different treatments similar to leukemia, but sometimes uses different chemotherapies. So chemotherapy is again used. There's different phases of chemotherapy. The treatment for AML tends to be a lot shorter than ALL. We also have incorporated different types of immunotherapy in treatments of AML. And again, this immunotherapy, such as gemtuzumab, are targeted agents that try to target a very specific target that is on these myeloblasts. Stem cell transplant can also be used in, again, patients that have very high risk AML based on their genetic features of their leukemic cells, patients that are not responding well to standard therapy, or patients that have relapsed even after chemotherapy has been given. And CNS prophylaxis with the intrathecal chemotherapy is also used in AML treatment. Chronic myeloid leukemia, this is the type of leukemia that is seen most commonly in adults, but we do see some pediatric patients that develop this. And the thing that makes chronic myeloid leukemia very unique is that it occurs in a cell where this genetic mutation has occurred. So there is basically an exchange of material from two different chromosomes on chromosome 9 and 22, where they exchange material and it results in this fusion protein that is known as BCR-ABL1 oncogene. And this leads to the activation of a tyrosine kinase, which results in the proliferation and the growth of this abnormal leukemic cell. So because it has a very specific mutation and genetic alteration that occurs, the treatment for this type of leukemia tends to be very different from the other types of leukemia. In children, CML represents about 3% of childhood leukemia. There's different phases of CML, and depending on the phase will depend on the treatment that that child receives. The most common phase is the chronic phase, CML. And this tends to be a very sort of like slow development. So usually symptoms occur over several weeks to months by the time the child actually presents to us, which is different from the acute lymphoblastic leukemia and the acute myeloid leukemia, because usually those symptoms, as the word insinuates, they're very acute. So children develop symptoms within a matter of days to weeks when they start getting sick. In chronic myeloid leukemia, children progressively get more sick and sick over weeks to months. The next phase is the accelerated phase, which is a little bit more severe because there are now more leukemic blasts present. And then the blast crisis phase. The blast crisis phase can present very similar to acute lymphocytic leukemia or acute myelocytic leukemia. It's more acute in its symptoms. So the treatment, because we have a very specific target in these leukemic cells, we use a very specific medication called a tyrosine kinase inhibitor. And it targets just this specific mutation that is in the leukemic cells. There's a lot of different generations of this medication. As you can see here, imatinib was the first one that was discovered, and now we have different generations, dasatinib and nilotinib, and a lot of others that can be used as well. If the CML presents in a more accelerated or in the blast crisis phase, then chemotherapy is also needed to help get that patient into remission, in addition to the tyrosine kinase inhibitor. And sometimes with leukemia that's not responding to standard medications, or that has come back after being in remission, we may consider moving forward with a bone marrow transplant as well. And of course, clinical trials is an option for all types of leukemia that have been either refractory to medication or have returned after they have been in remission. We can always consider clinical trials. And fortunately, there is a very large organization for childhood cancer called the Children's Oncology Group, which also has a lot of clinical trials open to patients with even ALL, AML, CML, all types of leukemias, sometimes for even upfront treatment. So now we'll move forward with talking about lymphoma. So lymphoma is a cancer of the lymphatic system. And we talked earlier about the lymphatic system and the different cell involved with the lymphatic system, the lymphocytes, and the different lymph nodes, where they're located, as well as our spleen, that all play a role in the immune system and are part of the lymphatic system. The two major types of lymphoma are Hodgkin lymphoma and non-Hodgkin lymphoma, and these also have different subsets as well that we'll talk about. So non-Hodgkin lymphoma usually also is an acquired type of cancer. So a person is not born with this type of cancer, it develops. And it develops in a specific type of white blood cell called the lymphocyte. The lymphocyte becomes cancerous and starts to grow, and it can grow either in the lymph nodes, in the spleen, in the liver, and these lymphoma cancer cells can also accumulate and kind of join together to form what's called lymphoma, or like a tumor. Patients that are affected by non-Hodgkin's lymphoma can be children, mainly between the ages of 10 to 20 years of age, and it accounts for 7% of cancer in children younger than 20 years of age. There are a lot of different subtypes of non-Hodgkin lymphoma. Here's a list of some of the more common ones that we see in children. But basically, in order to classify the type of lymphoma, there needs to be a biopsy, and we actually need to look at these cells under a microscope and do a lot of special tests on these cells to figure out what the different subtype is, because the treatment will be different for every subtype. Doctors can further classify non-Hodgkin lymphoma subtypes into categories depending on how rapidly they are growing and how they're responding to treatment. So aggressive non-Hodgkin lymphoma is usually classified as high grade, which means that it's a very fast growing lymphoma. And then there's certain types of lymphomas that can be more indolent, meaning they're more slow growing and low grade. So in order to make the diagnosis of non-Hodgkin lymphoma, as I mentioned before, we need to do a biopsy. So this biopsy can be done of the mass that's growing, of the lymph node that's growing, any area that may be affected by these lymphoma cells. And once a biopsy is obtained, we're able to send these tests to a pathologist, and the pathologist will look at these cells under a microscope, do all the special tests to figure out what type of non-Hodgkin lymphoma the patient has. There's a lot of different treatments depending on the type of non-Hodgkin lymphoma. Very similar to the other types of cancer that we've talked about. Chemotherapy is used. Immunotherapy can be used as well. Sometimes radiation therapy is needed. And in cases, again, where the lymphoma is not responding to treatment or has returned, we may consider doing what we call stem cell transplants, but sometimes it can be from another person or autologous stem cell transplant, meaning we use the stem cells from the patient. And there's also clinical trials available depending on the type of non-Hodgkin lymphoma and where we're at in treatment. Hodgkin lymphoma can also be seen in children. And again, this is similar to our other cancers. It's usually not inherited. It usually develops where there's basically a cancerous lymphocyte that develops and grows. Hodgkin lymphoma is most likely to be diagnosed in adolescents and young adults in their 20s and 30s. So it's important to always get a very good medical history, physical evaluation. And again, in order to make the diagnosis, we do need to do a biopsy to look at these cells and categorize which type of Hodgkin's lymphoma this is. There are two main types of Hodgkin's lymphoma. Classical Hodgkin lymphoma is the most common type in 95% of all Hodgkin lymphoma patients. And under classical Hodgkin lymphoma, there's different subtypes based on what we see under a microscope. The most common is nodular sclerosis. And the other type is nodular lymphocyte predominant Hodgkin lymphoma. This tends to be more indolent and slow growing and accounts for only about 5% of the cases of Hodgkin's lymphoma. Treatment is similar to the others. We use chemotherapy, immunotherapy, sometimes radiation, and sometimes stem cell transplantation. I'm going to talk a little bit about clinical trials because it's really been because of organized clinical trials that we've been able to really improve the survival rates of leukemia and lymphoma in children, adolescents, and young adults. So clinical trials is a very carefully controlled research study that's conducted by doctors and scientists. And the aim of these clinical trials is to improve treatment options for these patients, increase the survival rates, and also improve quality of life. So because we've been able to make so many advancements in the treatment of leukemia and lymphoma, our goal now is to really either increase our survival rates even higher than they already are, but also we want to decrease the toxicity of these medications. So, decades ago, we were starting to cure patients from their leukemia and lymphoma, but then we were finding that there was also a lot of long-term complications and toxicities that these patients would develop and sometimes even die from. So we're really trying to minimize the toxicities of these treatments that we're giving to cure leukemia and lymphoma. And these clinical trials are really designed to give patients the safest and potentially the most effective therapies. So who should participate in these clinical trials? Not everybody is eligible for these clinical trials. Of course, when we've ran out of treatment options, we do want to consider clinical trials that are more novel, using newer medications. But also we have clinical trials available even for upfront treatment. It doesn't necessarily just mean that clinical trials are available for only advanced or leukemias and lymphomas that have not responded to treatment. We have a lot of clinical trials, especially available through the Children's Oncology Group that is open to patients that have leukemia and lymphoma that are newly diagnosed. So patients do not have to necessarily wait, until treatment has failed. Families can also ask about clinical trials, but any children's oncology department, any major children's hospital that is treating leukemia and lymphoma is likely going to have studies available, clinical trials available. And I know a lot of the times when we think about clinical trials, we think about being a guinea pig, and we don't want our child to be experimented on. But when these clinical trials develop and become available, it's usually because there have already been extensive studies that have shown that these new medications are effective and safe in people that have leukemia and lymphoma. A lot of the times, these trials start in adults with leukemias and lymphomas, and then we start to include pediatric patients once we have seen how effective they are. So, I don't want family members to think that they're experimenting and they're going to be the guinea pigs and things like that. A lot of the times, these study drugs have already been extensively studied. So it's okay to ask your physician more about what trials have already been done with this medication. What are the side effects that we know about? Your treating physician should be able to go over that with you more in detail and give you some information. And some of the newer therapies, there are so many new therapies that are coming out every year. And some of these newer therapies are being presented at some of our national conferences. But some of the newer therapies that a lot of families have heard about and are asking about, one of them are something called CAR T cell therapy. So CAR T cell therapy has been used to treat leukemia and lymphoma that has either not responded well to standard therapy or has relapsed and come back, sometimes multiple times. And what this therapy includes is basically collecting T cells from the patient that has the cancer. And these T cells are then engineered to have special receptors on either the T cell or the chimeric antigen receptor. So they are then expanded and reinfused into the patient with leukemia and lymphoma so that these special cells can now target those cancer cells in the patient's body. And this type of therapy is available through clinical trials at certain institutions and is showing very promising results in helping to cure some of these leukemia and lymphomas that have been difficult to cure. So I just want to talk a little bit about taking charge of your child's health. If you are a parent that has a child that is being treated for leukemia and lymphoma, I really want to encourage family members and parents to really be an advocate for their child. As an oncologist, we really do listen to parents' concerns. If they tell us that something is not right about their child, something is just not being tolerated well, we really do listen to those concerns and take them very seriously. So it's important to really track each visit with the doctor and record what is discussed. Write down notes if you have to. It's hard to take in so much information. Make sure you're understanding everything that your physician or oncologist is explaining. If you don't, please feel free to ask questions. Please feel free to stop the physician and ask them to clarify something if you're not understanding it. Feel free to ask for copies of lab reports. You can also always get copies of your child's medical records from the medical record department. You can request those. Those sometimes usually are free, or there's a minimal fee if you want to get an entire chart. Discuss the test results. Ask for the results if you haven't gotten them. Make sure you understand them. Make sure that you are following up with visits and any tests that are being asked to get done. You can also seek medical, psychosocial support for fatigue, depression, and other side effects. I know that we have a wonderful psychosocial group as part of our oncology team, and we always refer our newly diagnosed patients and family members because we understand that this is a very stressful and difficult situation, and it's very life-changing. And so we understand that this not only affects the patient and the child that has just been diagnosed with cancer, but also the parents, the siblings, all family members involved. And so we want to make sure that everybody is getting support, because getting good psychosocial support is really going to help the child also cope with their illness and be able to be cured of their illness and tolerate things well. And also at the end of treatment, we want to make sure that your child continues to follow with an oncologist. Survivorship care is just as important as oncology care. So just because the child has been cured for cancer, we want to make sure they stay healthy. And the best way to do that is to make sure that you're continuing to follow with your oncology team. Once your child is far enough out from treatment, we want to make sure they are being followed by a survivorship care plan that really focuses and specializes at looking at the long-term and late effects of your child's chemotherapy and treatment. So that concludes our presentation on blood cancers. Thank you very much for joining and listening in, and thank you to the Leukemia and Lymphoma Society for inviting me to speak. I hope that you guys found this helpful, and hopefully if you have any further questions, you can speak with your doctor about those.
Thank you all so much for tuning in today. We hope you enjoyed this session. And again, thank you so much to the Leukemia and Lymphoma Society for this collaboration. If you have any questions regarding the presentation or services provided by the Pink Ribbon Place or the Leukemia and Lymphoma Society, please feel free to put your questions down below in the comment section. Also, don't forget to follow the Pink Ribbon Place at the Pink Ribbon Place for future presentations.